This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 9, Pulmonary Emergencies, Part 1. An introduction. Responding to pulmonary respiratory emergencies is a common occurrence for EMS professionals. The EMS professional must be able to act quickly and accurately when treating pulmonary emergencies. If needed, several drugs are effective in relieving pulmonary distress. Except for oxygen, most of the drugs presented in this chapter therapeutically work as bronchodilators. Pulse oximetry, and pretty much it is a standard of care in out-of-hospital or pre-hospital. Should be applied to the patient to establish a baseline vital signs, and pulse oximetry between 95 and 100% is normal, and we treat patients under 94% or 94% and under. We consider them hypoxic, so we supplement oxygen on them. 91 to 94% is mild hypoxia, 86 to 90% is moderate hypoxia, and below 86% is severe hypoxia. Capnography, continuous monitoring of carbon dioxide levels in the expired air. The end-tidal CO2, most common device used in the out-of-hospital emergency medicine. When end-tidal CO2 detectors indicate a lack of carbon dioxide in expired air, most likely the ET tube is in the esophagus. When CO2 is detected, the ET tube is most likely placed properly in the trachea. A good way of confirming endotracheal tube placement. Asthma, common respiratory illness that affects many people. Deaths have been on the increase for do over. Asthma, common respiratory illness that affects many people. Deaths have essentially been on the increase for those over 45 years of age. Approximately 50% of the patients die before reaching medical care. Prompt recognition followed by appropriate treatment can significantly improve the patient's condition and chances of survival. Whenever we look at bronchospasm, we look at a couple different problems in bronchospasm. One is being inflammation, that once we get all the inflammatory cells and things like that, the airway doesn't have no place to go, so it kind of swells to the inside, which this reduces the lumen of the airway. And then bronchial constriction, which is the smooth muscles and the bronchial tubes spasm because of their interaction with whatever the trigger was. And the airway should probably be this size up here, not this small. This is what's going to give us wheezing or trapping of air. So air will move in, but very simply, once it gets in there, it does not have the ability to come out. So their IDE times, inspiratory to expiratory times, will be expanded. So inspiratory will be normal, and then their expiratory times will be double, if not triple, what they normally would. Pathophysiology of asthma, chronic inflammatory disorder of the airway. Inflammation is usually associated with variable airflow obstruction. Major characteristics of asthma is reversible lower airway obstruction caused by edema, mucus, and spasm of the smooth muscle. The obstructions narrow the diameter of the smaller smooth muscle walls, bronchioles. Air is trapped behind the obstruction, preventing ventilation of the alveoli. Asthma is triggered by many different factors in the environment or psychological Two-phase reaction to triggers. Phase 1 is release of chemical mediators such as histamine, contraction of the smooth muscle, and leakage of the fluid from the alveoli. In some minor cases, this can resolve itself in 1 to 2 hours or through the use of bronchodilators. Phase 2 typically does not respond to inhaled beta agonists. Drugs and anti-inflammatory agents such as corticosteroids are used, usually last several days or weeks. Status asthmaticus is essentially one asthma attack after another after another after another. Severe prolonged asthma attack that in which the cycle cannot be broken by repeated doses of epinephrine or albuterol. Patient presents in severe distress and frequently has a greater distension chest from continual air trapping. Breath sounds and wheezing may often be absent. Patient is usually exhausted, severely acidic, and dehydrated. Cardiac arrest may be imminent on these patients. Management of asthma. Treating of asthma is aimed at correcting the hypoxia, reversing any bronchospasm, and treating inflammatory changes. And we do this through supplemental oxygen, beta agonists, which would more specifically beta-2 agonists. That's where we start off at, which tells the smooth muscle specifically to dilate. Corticosteroids, which would decrease inflammation. Leukotriene antagonists, which would decrease the amount of cellular mediated products that we see in the inflammatory process. And then, last but not least, intubation or mechanical ventilation. Chronic obstructive lung disease. Chronic obstructive lung disease is a combination of two diseases. Examples of this would be asthma and chronic bronchitis, or asthma and emphysema, or chronic bronchitis and emphysema, or all three. Asthma is an airway disorder that causes respiratory hypersensitivity, inflammation, and intermittent obstruction. Asthma commonly causes constriction of the smooth muscles in the airway, wheezing, and dyspnea. Chronic bronchitis is damage to the endothelium, impairs the mucociliary response that clears bacteria and mucus. Inflammation and secretions provided the obstructive component of chronic bronchitis. So you essentially get bronchitis chronically again and again and again, and your mucus secretions continue to build that are in your lungs. Emphysema. Physiology of emphysema involves gradual destruction of the alveolar septa and of the pulmonary capillary bed, leading to a decreased ability to oxygenate blood. Now, if I told you subcutaneous emphysema, you would say, well, it's trapping of air in the subcutaneous tissues. And pulmonary emphysema is trapping of air in the alveolar sac. And without circulation of the airflow over the alveolar sac, you don't really get respiration. Emphysema is the destruction of lung parenchyma, leading to the loss of elastic recoil and the loss of the alveolar septa and radial airway traction. This increases the tendency for airway collapse, lung hyperinflation, airflow limitations, and air trapping follow. Air spaces enlarge, and they may even develop a bulba, which is essentially a blowout. Antiasthmatics. So we're going to talk about oxygen, albuterol, Atropine, Aminophylline, epinephrine, Racemic Epinephrine, and Terbutaline. First on our list, oxygen, the most important drug to use in the management of respiratory emergencies. Without oxygen, the body cannot sustain itself and death will occur. It is essential to use in any case of suspected hypoxia from any cause. Administration of oxygen raises the inspired percentage of oxygen, raises the oxygen concentration at the alveolar level, raises the arterial oxygen levels, and raises the amount of oxygen delivered to the patient's cells. Reduces hypoxia and volume of respiration necessary to oxygenate the blood. Oxygen saturation needs to be less than 94% to administer. Use with caution in infants and lower rates with patients in COPD. Do not get this incorrect though. If our patient, we should treat the patient. So our COPDer, if they have hypoxia, we treat the hypoxia. If it leads to an intubation, it leads to an intubation. Oxygen delivery devices. So the nasal cannula increases the oxygen. Now this is percentage delivered Now, remember, we're delivering 21% already from the atmosphere, so this increases it 24 to 44%. Simple face mask up to 60. Venturi mask 20 to 50. Partial non-rebreather up to 60%. Non-rebreather, and this has a reservoir bag, which is up to 95%. Bag valve and mask with reservoir up to 90%. And a demand valve is 100%. Alright, so bronchodilators. Whenever we talk about bronchodilators, we primarily are talking about beta-2 agonism or beta-2 agonists. And what that means is they stimulate this beta-2 receptor site. Now what this does is this forms adenylene cyclase, which then enzymatically changes ATP into cyclic adenosine monophosphate, and what we get from that is smooth muscle relaxation. So it's really like talking to one receptor so that we get the product that we want rather than the whole kit and caboodle. Now the thing is with this is these are so closely related, beta 1 and beta 2. Beta 1 is harder, faster, and stronger receptor on your heart. So higher doses of the beta 2 agonist will also give us beta 1 responses, which means our patient will have a higher heart rate, they may be tachycardic, it may give them some cardiac symptoms. Everybody's going to be a little different, so just be aware of that. So albuterol, primary care drug, and that's what this up here means. Generic on this drug is going to be albuterol, and the trade is going to be Preventil. Mechanism of action: albuterol is a relatively selective beta-2 adrenergic. The prime action of beta adrenergic drugs is to stimulate adenylene cyclase, the enzyme that catalyzes the formation of cyclic 3,5 adenosine monophosphate, or cyclic AMP, from adenosine triphosphate. The cyclic AMP causes relaxation of the smooth muscles of the bronchial tree. Adult dose in this is going to be 2.5 to 5 milligrams, and if it isn't already pre-mixed, we need to mix it with 3 mils of normal saline and nebulize it. Pediatric dosage are going to be 0.15 milligrams per kilogram and a maximum on that of 3 doses. Contraindications are going to be any hypersensitivity to the drug or angioedema. Pharmacokinetics: this is going to start working in about 5 to 15 minutes, or the onset. The peak is going to be this is going to be the duration of the drug, 1 to 1.5 hours. And then duration of the actual drug in the system is going to be about 3 to 6 hours. So this is going to be metabolized in the liver and eliminated in the urine. This is a general knowledge drug, GK. Generic on this is going to be the name Aminophylline, and the trade name is going to be Somophylline. Mechanism of action: prolong the effects of beta agonists by blocking the enzyme phosphodiesterase that biodegrades them. As a result, the beta 2 effects, or the bronchodilation and decreased mucus secretion, are prolonged. Although mexylxanthanes are primarily used for long-term airway maintenance and COPD, Aminophylline is sometimes effective for patients refractory to sympathomimetics or other bronchodilators. Break that down for you here really quick. So we put this drug on board, and it gives us more bang for our buck and prolongs the effects of the beta 2 agonists. In addition to that, anybody that's refractory to any kind of sympathomimetics or bronchodilators, this medication might be effective. So what refractory means is that it didn't work like we expected it to work. So this makes our catecholamines or sympathomimetics work better. The adult dose in this is 5 milligrams per kilogram, IV infused over 20 minutes. Contraindications to this medication: hypersensitivity or uncontrolled cardiac arrhythmias. If they're already tachycardic or tachydysrhythmia, this medication here is going to speed things up a bit. It might just push them over the edge. Pharmacokinetics on set and duration vary. It's protein-bound, active metabolite, and excreted in the urine. Atropine, primary care. Mechanism of action: the generic on this is atropine, and the trade is atropine. Mechanism of action. It's a competitive antagonist, so that means that it blocks. Let's just break this down as we go through. That selectively blocks all muscarinic responses to acetylcholine. By blocking vagal parasympathetic impulses to the heart, it increases SA node discharge, enhances conduction through the AV junction, and increases cardiac output. Now, it blocks the parasympathetic nervous system. Another verbiage for this would be parasympathetic. So we have the sympathetic and the parasympathetic nervous system here. And they kind of work like a teeter-totter. So if we block this, we decrease its tone, thereby alleviating a sympathetic dominance, which would make the heart beat harder, faster, stronger. Adult dose in this is going to be 0.5 to 1 milligram. And please push this quickly. If we push it slow, we'll get adverse effects. 3 milligrams max. Pediatric dosing is going to be 0.02 milligrams per kilogram with a max of 0.04 milligrams per kilogram. Contraindications, sensitivity to the drug, glaucoma, acute myocardial infarction, cardiac ischemia, GI obstruction, or myasthenia gravis. And myasthenia gravis is a parasympathetic disease, so symptoms of this disease would be tenfold. Pharmacokinetics would be IV onset immediately, peak in 20 to 60 minutes, and a duration of 4 hours. This is metabolized in the liver and eliminated in the urine. Atropine, also a primary care drug. The generic on this is ipratropium bromide, and the trade name is Atropine. Mechanism of action. It is an anticholinergic or parasympathetic agent. Inhibits vaguely mediated reflexes by antagonizing acetylcholine action. Prevents an increase in intracellular calcium concentrations, which is caused by an interaction of acetylcholine with muscarinic receptors on the bronchial smooth muscle. So this robs them of their ability to contract. The adult dose, 0.5 milligrams nebulized. The pediatric dose is 0.25 to 0.5 milligrams nebulized. So we give half to the normal adult dosing in pediatrics. Contraindications, hypersensitivity, also to atropine or its derivatives. Pharmacokinetics, onset of this atropine is going to occur in about 15 minutes. Duration is going to be about 3 to 4 hours. Metabolites in the liver and excreted in the urine. Epinephrine, primary care drug. Generic and trade are both epinephrine. Epinephrine is a naturally occurring catecholamine obtained from animal adrenal glands, but also prepared synthetically, and today we use mostly the synthetic version. Acting directly on both alpha and beta adrenergic receptors, it's the most potent activator of alpha receptors. Epinephrine imitates all actions of the sympathetic nervous system except those on the arterioles of the face and sweat glands. So what this does is this is a shotgun blast of all of our adrenergic receptor sites. Now, what that means is in the case of bronchospasm, this is the one that we're wanting to stimulate. However, epinephrine is going to blast all of them. We're going to get vasoconstriction, harder, faster, stronger, and bronchodilation. Sometimes it's better to shotgun the entire receptor site than just to specifically try to keep pleading with one of them to work. Now, what we will get with this is tachycardia, extreme amounts of tachycardia. This could push someone over the edge that had coronary artery disease in their history. Adult dose in this for asthma and allergic reactions is 0.3 to 0.5 of a 1 to 1,000 solution, and that's going to be sub-Q or IM. Maximum amount on this is going to be 0.5 milligrams. In anaphylaxis, 0.1 milligrams per kilogram of a 1 to 10,000 solution. We also cap it at 0.5. Can be given IV or IO. Pediatric dose, cardiac arrest, 0.01 milligrams per kilogram of a 1 to 10,000 solution every 3 to 5 minutes. Now, this is one of the most commonly used drugs in EMS is epinephrine. Contraindications on this is going to be glaucoma, if they're in shock, hypovolemia more specifically, have organic brain system, or any type of coronary insufficiency. Now, if their coronary arteries are already clogged up and you increase the workload on the heart, it doesn't take much of a rocket scientist to figure out that we're probably going to push them over the edge and may actually do cardiac damage. Pharmacokinetics, onset in less than 2 minutes. Duration is going to be 5 to 10, 20 to 30 in the sub-Q version. Metabolized in the liver and excreted in the urine and breast milk. Xopenex, general knowledge drug. Generic on this is level albuterol. The trade name is Xopenex. Mechanism of action, level albuterol binds to beta-2 adrenergic receptors to cause bronchodilation. Xopenex has a greater affinity with beta-2 and gives a reduced beta-1 response. So Barney version of this, or the broken down version of this, is this does give us our beta-2 specific. It's a lot more selective than albuterol, but it doesn't have it does not have as great of an affinity for the beta-1. So we don't get the tachycardia and the increase in heart rate and contractile force strength that we would with albuterol. We more commonly get bronchodilation, and that's about it, with very little, if any, adjustment of heart rate. Adult dose on this is going to be 0.63 milligrams by nebulization 3 times a day. Pediatric dose of 0.16 to 1.25 milligrams nebulized. Contraindication, known hypersensitivity to level albuterol or albuterol. It's a close cousin. Pharmacokinetics, half-life in 3.3 hours. Peak plasma, 12 minutes, and is excreted in the urine. Racemic epinephrine, general knowledge. This is something that they use on smaller individuals or children that have croup-style cough or bronchospasm and upper airway swelling. This works very good in bringing about alpha-1 responses along with the beta-2 bronchodilation effects. Kids that have seal-like coughs are coughing against a closed airway. So this is a response to hypoxia. So the generic on this is Racemic Epinephrine. The trade name is micronephrine. Mechanism of action. Racemic epinephrine is slightly different chemically from the epinephrine compounds that have been discussed previously. Compounds that differ only in their chemical arrangement are called isomers. This particular form is frequently used in children to treat croup. Racemic epinephrine stimulates both alpha and beta adrenergic receptors, with a slight preference for beta-2 receptors in the lungs. Adult dose is 0.25 to 0.75 milliliters of a 2.25% solution and 2 mils of normal saline. Now, there is no way that we can make this in the back of the truck. A 2.25% solution would be about 22.5 milligrams of epinephrine. It's a very large concentration strength. There's no way that we can concentrate it in the back of the truck. So if we do not have this with us in EMS, we cannot make it out of our 1 to 1,000. What we should look at and consider is take a look at the patient's physical condition. And would they benefit from maybe a loading dose of epinephrine? If it's not in your current protocol, the easiest way to do that would be to facilitate a consult with a medical control physician and ask permission. Pediatric dose is the same as an adult. Contraindications, racemic epinephrine is contraindicated in patients with a hypersensitivity to the drug, those with potential for tachydysrhythmias and hypertension and epiglottitis. Pharmacokinetics, onset 1 to 5 minutes, duration 1 to 3 hours, metabolized in the liver, and excretion is unknown on this. Terbutaline. This is going to be a general knowledge. Generic on terbutaline. The generic is going to be terbutaline, and the trade name is going to be breathine. We don't use this so much anymore as a bronchodilator. It is a bronchodilator tocolytic agent, which means that it can stop also Uterine wall contractions. So we want to stop the contractions. A tocolytic agent would be used. Mechanism of action. Terbutaline is a beta-2 adrenergic agonist having strong effects on pulmonary receptors. Terbutaline relaxes bronchial smooth muscles, resulting in an increase in lung capacity and a decrease in airway resistance. Now, it is not so selective. It will also give you very, very aggressive beta-1 stimulation as well. So, we will get tachycardias and increased contractile force strength. Their heart will feel like it's beating out of their chest. Adult dose on this subcutaneous is 0.25 milligrams, and repeat this about every 15 to 30 minutes as necessary. Contraindications: a hypersensitivity to adrenergic amine drugs. Pharmacokinetics: onset within 15 minutes. Duration is 90 minutes to 4 hours, and excretion is about 60% in the urine. Drug affecting the central nervous system, and these drugs are going to be diazepam, Versed, and etomidate. I'd like to talk here really quick about how a Gaba agonist works. So, very simply, when this is a neural cell, or this is your brain cell, how a Gaba agonist works is you have a sodium-potassium pump that generates an action potential. And the more positive the inside of the cell gets, the greater chance you have of creating an action potential, and it's going to give off electricity in the cell. Now, what a GABA agonist does is whenever the GABA receptor site is stimulated, and this would be through the use of a benzodiazepine. I'm going to switch colors here really quick. Once the benzodiazepine hits its subunit, GABA then is utilized. And what it does is it allows in negative chloride ions into this channel. Now, very simply, the inside of this cell needs to become more positive, not negative. So this is going to decrease the amount of action potential that the cell has. In the case of the neuron, this would decrease level of consciousness and decrease your ability to go into a seizure, because I just decreased your ability to formulate an action potential. Diazepam, primary care. Generic on this is going to be diazepam, and the trade name is going to be Valium. Mechanism of action. Diazepam is a benzodiazepine whose exact mechanism is unknown, but many believe it appears to act on both limbic and subcortical levels of the CNS. It is principally used for its anticonvulsant properties. It suppresses the spread of seizure activity through the motor cortex of the brain, and we pretty much think that it works on GABA agonist or GABA, gamma-aminobenzoic acid stimulation. Adult dose for seizures is going to be 5 to 10 milligrams, IV, IM, or intranasal. For cardioversion, 5 to 15 milligrams IV. Pediatric dose for seizures, 0.5 to 2 milligrams IV, IM, or IN, or rectal. For cardioversion, 0.2 to 0.5 milligrams per kilogram IV. Contraindications: glaucoma, CNS depression, alcohol intoxication, or just sensitivity in general to the drug. Pharmacokinetics: erratic IM absorption for IV onset 1 to 5 minutes, 15 to 30 minutes in the IM, and duration is going to be from 15 to 60 minutes. Half-life is from 20 to 50 hours, metabolized in the liver and excreted in the urine. Versed. Generic on Versed is going to be midazolam, and the trade name is going to be Versed. Mechanism of action. Midazolam is a short-acting perennial benzodiazepine with CNS depressant, muscle relaxant, and anticonvulsives and antegrade amnesic effects. Its exact mechanism of action is unclear. Intensifies activity of gamma-aminobenzoic acid, or GABA, a major inhibitory neurotransmitter of the brain. by interfering with its reuptake and promoting its accumulation at neuronal synapses. Adult dose is going to be 1 to 2.5 milligrams slow IV push, IM or intranasal. 5 milligram is the usual dose for procedures whenever we want amnesic effects. We don't really want our patients remembering us transcutaneously pacing them or synchronized cardioverting them. Adult dose, that's what I just got through talking about. Pediatric dose is 0.05 milligrams per kilogram to 0.20 milligrams per kilogram. Contraindications for midazolam. Midazolam is contraindicated in patients with an intolerance to benzodiazepine, acute narrow-angle glaucoma, shock, coma, and acute alcohol intoxication. If they're already got drugs on board, in this case ethanol, why would we put on board more drugs that would potentiate it? Pharmacokinetics, onset in 35 minutes with a peak in 20. Duration is less than 2 hours. This is metabolized in the liver and excreted in the urine. Etomidate, primary care drug. Generic on this is going to be etomidate, and the trade name is going to be amidate. Mechanism of action. Etomidate is an ultra-short-acting, non-barbiturate hypnotic with no analgesic effects, used for facilitation of intubation. You can also use this for conscious sedation as well. It produces a rapid induction of anesthesia with minimal cardiovascular and respiratory effects. Adult dose on this is going to be 0.1 to 0.3 milligrams per kilogram IV over about 15 seconds. And very simply, it does not hurt to push it up to a minute. You will have less untoward effects with this medication. Pediatric dosage, children older than 10 years old, is the same as an adult. Contraindications. Etomidate is contraindicated in patients with a hypersensitivity to the drug. We're pretty sure this also works on Gaba. It's our best guess so far. Pharmacokinetics, onset in 10 to 20 seconds, peak in 1 minute, duration 3 to 5 minutes, half-life of 30 to 74 minutes. This is metabolized in the liver and excreted in the urine. This ends part 1, and these are the references. Beck Pharmacology for EMS Providers, Del Mar Learning, and Brian Bledsoe, Pre-Hospital Emergency Pharmacology, 7th edition. And these are various spots on the internet that I got various pictures from. If you have any questions concerning this chapter, feel free to give me a contact. My name is Roy Smith, smithr@emsa.net, or 405-219-7613. Thank you.